Hello and welcome to the Oncology Resident. We use visual aids to help make key oncology concepts easy to understand. In this video, we will go through the ICRU definitions. It's worth noting that these definitions have evolved over time, most notably through ICRU reports 50, 62, and 83, with report 83 providing updated guidance specifically for IMRT. These volumes are defined and contoured on a 3D radiotherapy planning scan. The gross tumour volume is the gross tumour defined from a reconstructed 3D image of the patient, such as a CT, MR or PET scan and clinical examination. In practice, multimodality imaging is often used, for example, combining CT with PET, as different modalities highlight different aspects of the tumour, allowing for more accurate GTV definition. It's usually split into GTVP, the GTV primary, and GTVN, GTV nodes. The CTV is the clinical target volume. This tissue volume includes the GTV and subclinical or microscopic disease that has to be treated to an adequate dose to achieve the aim of the therapy, whether it's cure or palliation. It is constrained by anatomical boundaries such as bone. Expanding the GTV to the CTV stems from an understanding of particular disease pathology, and CTV margins are typically guided by published clinical guidelines from bodies such as RTOG or ESTRO, depending on the tumour site and histology. These are both clinical volumes. The internal margin is the margin added to the CTV to compensate for expected physiological movements, such as variations in size, shape, and position of the CTV due to internal organ motion. Usually, this is relevant for tumours adjacent to the digestive or respiratory system. The ITV is the internal tumour volume. It's a combination of the CTV and the internal margin. This ensures that the tumour remains within the radiation field throughout the treatment. This is used in 4D planning scans in which motion tracking is done to assess tumour movement over time. The setup margin accounts for uncertainties in the relationship between patient and beams. It is worth noting here that image-guided radiotherapy, or IGRT, plays an important role in reducing this uncertainty. By using daily imaging before treatment, setup errors can be corrected in real time, which can justify smaller setup margins and therefore a smaller PTV overall. The PTV is a planning target volume. This is a geometrical margin for setup error and organ motion. It's a combination of the internal margin and a setup margin. It's important to know that the GTV and CTV are clinical parameters, and the PTV is a geometrical parameter. The treated volume is a volume receiving more than 95% of the dose, sufficient to achieve the purpose of the treatment. The irradiated volume is the volume receiving more than 50% of the dose, a dose that is significant for normal tissue tolerances. The Conformity Index is the quotient of the treated volume and the volume of the PTV. It is used to compare different treatment techniques, with the aim of getting this as close to 1 as possible. The hotspot is anything outside the PTV receiving 100% of the dose. In any plan, you need to consider nearby organs. The organs at risk are vulnerable to radiation sensitivity that may influence treatment planning or prescribed dose. It is useful to distinguish between serial organs, such as the spinal cord, where even a small volume receiving a high dose can cause serious harm, and parallel organs, such as the lung, where a larger volume can tolerate a moderate dose. This distinction directly affects how dose constraints are applied in planning. The planning organ at risk volume is the organ at risk plus a margin for movement error. When contouring a plan, you'll go through each of these volumes before passing it on to the physics team for planning. The references will be linked below. If you found this helpful, subscribe to follow along for more videos. Thank you for watching.